in addition to nephrology. I took that credential because I've always had a very special interest in hypertension. You guys are going to be doing a lot of hypertension management, whether you work at the urgent care, whether you work in the ER, whether you work as a hospitalist or as an internal medicine doctor. You're going to be dealing with a lot of hypertension management. But the key thing and the take-home message from this talk is that I want you guys that every time you're confronted with a hypertension patient, you're going to cover what I call your ABCs. You know, when they're teaching you CPR, that they teach you airway, breathing, circulation. I'm going to teach you the ABCs in hypertension. If you don't do that with every patient, you're not doing a good job. And you're going to understand very soon what I'm talking about. Can you please help me read the first case?
A 55-year-old man is referred for chronic resistant hypertension despite taking lisinopril, chlorthalidone, and lidocaine and metoprolol. He is complying with his medications. He drinks 3 to 4 alcoholic beverages per week. He does not take NSAIDs. He denies adding salt at the table. He snores but denies hypersomnolence or headaches, and his wife is unaware of apneic episodes. His blood pressure is 160/90, consistent with home readings. He is obese, BMI 35, and has 1+ pitting edema. His creatinine?
Yeah.
Creatinine is 1.0 and potassium is 3.8, and your analysis is negative for albumin of cells. His TSH is normal and his serum calcium and PTH are normal. Which of the following is most correct? A, his alcohol intake is likely contributing to his resistant hypertension. B, a high sodium diet is not contributing to his hypertension. C, polysomnography would most likely be positive for sleep apnea. Or D, polysomnography is not indicated since he does not have specific symptoms of sleep apnea.
What do you think?
A.
So we're always taught about alcohol consumption and secondary hypertension. I'm going to show you, somebody's looking into this. Actually, they've done studies. And what was the other option? C. Okay, that's probably the correct answer. So let's cover and then we can go back. So you guys know what the definition of resistant hypertension is? So it's blood pressure that remains above goal despite the use of 3 antihypertensive medications, and including a diuretic. So this is the American Heart Association statement. I think it was like 2008 when they came up with this definition. And you're going to get a lot of patients with this label of resistant hypertension. But there's also another subgroup of patients that we easily overlook, are those that are actually controlled, but they're already taking 4 medications. So if you have a patient with 4 medications, you can very comfortably call it resistant hypertension. These are the numbers. Actually, the prevalence of resistant hypertension is actually pretty impressive, because on epidemiologic data, up to 27-30% of the patients, they fulfill this criteria. But when you eliminate for confounding factors, and this is one of the take-home messages, is that you have to eliminate what I call pseudo-resistance, which is how much sodium you have, how much exercise you're doing, and how much weight reduction you're able to accomplish. And let's review your diet. Those are the ABCs in hypertension management. Because we know that when you get a question on your boards, they're going to want to have you answer medication management, but it is reasonable not to start treating medications right away unless they're very hypertensive, and you can prescribe a good exercise, weight reduction, and sodium restriction regimen. What I normally do is that I do refer my patients for a formal dietary consult, because I have that available in my practice. You guys can always partner with a community dietitian. Some people have private practices, like Dr. Ben-Zur. They have a dietitian in the community, and you refer your patients, because that's probably the most useful advice you can give to somebody with hypertension. Be aware that in your boards, they're gonna want to trick you with a patient that's actually using medications that are associated with hypertension. You guys know which ones I'm talking about? Like a young female taking OCPs, you're gonna get a question like the best next step in the management is change the OCPs to something else. Don't stop it, because the baby's gonna be yours. But OCPs, estrogen-based OCPs, are associated with hypertension. Same as NSAIDs. NSAIDs are actually very commonly seen on your boards. They give you a patient that's taking ibuprofen for whatever reason and blood pressure is in the 140s, 150s. The best next step in the management is stop the ibuprofen. This is actually classic internal medicine question. So I want you guys always to look for secondary causes. Do you guys know which other medications are associated with secondary hypertension? Which medications you guys remember? Which one? Well, if you're hyperthyroid, both hyper and hypothyroidism can be associated with secondary hypertension. Yeah, so excessive levothyroxine can cause that. What other medications you guys remember? Do you guys like sports? You know who Lawrence Armstrong was? Steroids, definitely steroids. So EPO, the guy was abusing EPO. I don't know if you guys follow cyclists. The guy was abusing EPO. And by definition, by recommendation from the FDA, you're not supposed to administer EPO if the patient's systolic blood pressure is greater than 160, because it is expected that you have like a 10 or 20 point increase in your systolic the few days after administration of EPO. There are other medications that probably you don't need to know about, but I'm going to mention them just in case. We have calcineurin inhibitors. Have you guys heard about tacrolimus and cyclosporine? So when you guys see a transplant patient, both medications, probably cyclosporine more than tacrolimus, are associated with secondary hypertension. And we have other cancer agents, the anti-VEGF, vascular growth endothelial factor inhibitors, that there are many label and off-label indications for using these medications, but it's mostly used for solid organ malignancies like ovarian cancer or gastric cancer. Have you guys heard about Avastin? So those medications, if you end up working with cancer patients, you're going to see a lot of these side effects in clinical practice. But anyway, the bottom line is that if you get a board question, just make sure you don't jump and you answer treatment. You need to exclude pseudo-resistance by making sure that the patient is not taking a medication associated with secondary hypertension, but making sure the patient is not doing excessive alcohol. Excessive alcohol is like more than 25, 27 drinks per week. That's a lot. So that means that if your patient asks me, hey doctor, can I have one glass of wine? Never say no, because there's really nothing wrong with one glass of wine. I mean, more than that is probably an issue, but for your boards, it's okay to answer one glass of wine a day. Make sure that you're not dealing with somebody excessively eating sodium. Do you guys know where most of the sodium is coming from? Do you think it's from people adding it?
No.
Where is it coming from? Processed food. So processed food. So on average, you guys know what the American Heart Association recommendation on sodium intake is? It's 2,000 milligrams per day. On average, like they've done studies looking at people's urine, because that's how you measure how much sodium you have in a 24-hour period, by measuring your 24-hour urine sodium excretion. They give you that number in milligrams, and you multiply that by the molecular weight of sodium, which is 23, and you convert that into milligrams per deciliter. So the average American consumes about 4,500 to 5,000. This is an average person. I'm not talking about somebody who's addicted to salt. And some patients are going to come telling you, like, I love salty stuff. Your advice is going to always say, like, salt is horrible. That's been demonstrated across the board. We know that rats that are salt deprived or food deprived, they live longer than the ones that are actually like overfed or excessively fed with sodium. And another important consideration in clinical practice is the white coat effect. Have you guys heard about that? I'm pretty sure you had. How do you rule out white coat effect, white coat hypertension?
Check their BP at home.
Very good. And if you want to write the correct textbook answer, what is the gold standard to rule out white coat hypertension?
5 minutes or wait some time and then recheck it?
No, it's actually a test called a 24-hour ambulatory blood pressure monitor. An ambulatory 24-hour blood pressure, I've been meaning to have Dr. Ben-Zur get a couple for the office, because it's very useful. And more and more guidelines are suggesting that this is the correct way of diagnosis on hypertension. But you can imagine like doing a 24-hour ambulatory blood pressure monitoring for everyone is probably not feasible, and it's going to be costly. But there are very strong clinical indications to do a 24-hour ambulatory blood pressure monitoring, and one of them is to rule out white coat hypertension. The monitor will be helpful diagnosing white coat hypertension, mask hypertension, like patients that actually come to the office and they have normal blood pressure readings but they're running higher at home, and to diagnose patients with a non-dipping pattern on the sleep. You guys know what a dipping pattern is? Physiologically, you guys remember that the blood pressure usually goes low when we sleep. So typically we get about 10 to 20 points of reduction in the systolic blood pressure when we sleep. The non-dippers is associated with two things. It's associated, number one, with the sleep apnea. So if they show you an ambulatory blood pressure monitor and there's no dipping, so that person has a sleep apnea until proven otherwise, number one. And number two, those patients, we know that from epidemiologic studies that they're at risk of higher complications related to hypertension. In other words, the non-dippers, they have a higher risk of strokes, heart attacks, and so on and so forth. So that's why it's important in clinical practice, when we have a patient, to modify the risk. That's when we do this kind of test. Okay? So, very good. And then for those patients that actually you exclude everything else, we have the typical secondary hypertension. I always tell the doctors in my group, I'm the champion for the hypertension committee, so I go to a bunch of meetings and I meet with the doctors that are struggling with hypertension control, and I tell them hypertension management is not rocket science. It's just a good internist work. Why? Because you need to sit down with the patients, you need to assess medication compliance. Do you guys think that non-compliance with medications is a common clinical problem? You better believe it. It's very common. Actually, some pharmacy studies show that up to 27 or 30% of patients don't take the medications as prescribed. So you need to do your homework. How do you assess for compliance with medications? What are the strategies that you guys know? How can you assess? Right, but objectively, like you're asking your patient, like, are you taking your medications? The patient is going to say, yes, I am, but how do you prove or disprove that? Well, you can do labs, but that's not feasible in clinical practice because most medications is a send-out lab, it takes forever and it's not practical. So if you work in a managed organization, it's easy by looking at the electronic health record because they get the prescriptions from the same place that you're prescribing them. So it's easy to know when they bought it, when they refill it. Another thing, like if you're doing a community practice like here, ask the patient to bring the bottles and look at the dates. And you can even count the pills. I've had patients telling me, like, I'm taking them. When I tell them to bring me the pills, they're like from 2015, 2014. Like, of course you're not taking them. So, and for whatever reason, you would expect people will tell you the truth, but they're not. They're either afraid of you or they don't want to disappoint you. Whatever, people have like erroneous beliefs. So you always want to have a very clear line of communication with your patients because they don't teach you this in medical school, but if you want to be one of the best performing physicians in your group or in your practice, I'm going to tell you that there is nothing that will take you to a level better than communication. And communication is creating empathy, is creating a good therapeutic relationship between you and your patient, and do a non-confrontational approach. You're there to help them. When patients come to me, I tell them I just want you to be honest because I'm here to help you. And I want to understand how can I help you in a better way. So whatever your language, whatever your ability to develop a relationship with that patient, I'm going to tell you this is probably the most important tip I can give you for a successful practice: communication. Is that easy? It's not easy because it's easier to prescribe and move on to the next patient, and it's a lot harder to sit down and listen. And sometimes when you open the possibility of talking, you end up opening can of worms that you don't want to hear about, like other problems that are abandoned or psychosocial needs or whatever. But an effective physician taking care of hypertension, this is what you need to do: communication. I don't know if you guys know that there is a disparity between Caucasians and Hispanics and African American rate controls, and we know that the disparity is about 4 or 5 percentage points. between the Caucasians and the African Americans. At least that's the data that I have in the committee, and for numerous reasons. And I don't know how much you guys know about the origin of the distrust of the African American with the non-black physicians, but back in the 1930s, and this is actually documented historical facts. Back in the 1930s and the 1940s, they were conducting experiments purposely infecting African American patients with syphilis, and to look at the long-term effects of syphilis, and that only came out in the 1960s. But that was not the only disturbing thing. What was really disturbing is that it took more than 30 years for a government official to publicly apologize to the African American community for conducting those kind of experiments. So that's even worse than actually discovering or uncovering the whole thing in the 1960s. Up until 1997, nobody had apologized to them. So they have different needs, and they have a lot of distrust from you guys. So don't expect like you're gonna be smile, you're gonna be nice to them, they're gonna do whatever you tell them to do. They're not. So you need to do a lot of hard work, a lot of patient work, understand their needs, and talk about it. You know, I've heard from my African American patients, I've heard like those medications were done for white people, and there's a lot of truth to that statement because a lot of the studies were done in non-African Americans. So when you have to listen to your patients, you would understand why they're not taking the medication. So compliance is a huge issue in clinical practice. So I want you guys happens in the kidney. So you have kidney disease, you have limited ability to synthesize vitamin D. So vitamin D, it actually is a direct inhibitor of PTH transcription. So when you give your patients vitamin D and you replete the vitamin D level to a goal of 30, you're effectively inhibiting PTH production. So that's how we treat secondary hyperparathyroidism in kidney disease. We give them less phosphorus in the diet. You guys haven't answered my question. And you give them vitamin D to suppress production of PTH. So what are the highest phosphorus foods? Sorry? No, that's potassium.
Green leafy vegetables.
That's potassium.
Fruits?
No,
Is
potassium.
It a healthy food or is it
It's actually, people think it's healthy. I don't think it's healthy. Milk. Milk has the highest content of phosphorus. So any type of dairy products, processed foods, they have a lot of phosphorus, like as part of the preservatives. Like chips, like nuts. A lot of the nuts have a lot of phosphorus. Ice cream. Dark sodas have a lot of phosphorus. So a kidney disease patient should never have a dark soda. Yeah, no one should have a dark soda, period. I mean, I'm very strict with that, but trust me, it's like, yeah, that's actually the way I do it. But I know we all drank dark sodas at one point in our lives, but there's nothing good about those things. So dark sodas are a big no-no for a kidney disease patient because they have a lot of phosphorus. So yeah, so those are primarily the things. But going back to primary hyperparathyroidism, that's how we got into this conversation. So you guys know that there is primary, secondary, very different physiopathology, and tertiary hyperparathyroidism. You guys know what tertiary hyperparathyroidism is? So basically your parathyroid glands, they go nuts. They don't care whether or not you have some stimulus to suppress the production. They don't hear anything. They just have one mission. They're gonna become the size of a bean. You know, the parathyroid glands are the size of a lentil. So when they go crazy and they get pretty big, they can become the size of a bean. And they can start producing PTH in the thousands. Do you guys know why is it important that we treat those patients? What happens when you have a lot of PTH? You guys know? You can have, depends on, if you have normal renal function, you can get really bad osteoporosis. But if you have advanced kidney disease, you can get different spectrums of bone disease. You know, we have like what we call the renal osteodystrophy. You can have something called adynamic bone disease, or the other spectrum of disease, which is, one is because of a lot of resorption, the other one is because you don't have any resorption, and they're both equally bad. So that's one thing that's probably the most common. Patients can complain of bone pain, but more and more research is showing that PTH is associated with cardiovascular outcomes, poor cardiovascular outcomes, hardening of the arteries, like severe hypertension and cardiovascular mortality. So that's why it's important that we treat these patients. And the treatment of tertiary is surgery, or there is a medication. It's a calcium mimetic agent. It's called Sensipar. Have you guys seen any patients with Sensipar in the medication list? Sensipar, cinacalcet. Have you guys heard about that drug? So it's made by Pfizer, I think. And it's Amgen, actually. Amgen that makes Sensipar is a multi-billion dollar drug because there's no generic and there's no competition. Sensipar cinacalcet. So it's very effective suppressing PTH production, but 20% of the patients, they can't tolerate it. It causes a lot of nausea and vomiting. And for those, there's no other way of doing surgery. Okay? So, and then on the small print, I put 3 very, very uncommon causes of secondary hypertension. I've seen Cushing syndrome in my practice. I've seen FEO twice. Is FEO common on your boards? Yeah. You better believe it. Is it common in real life? No. There you go. So, but make sure you guys, at least the night before your boards, make sure you grab your book and you read about Men 1 and Men 2, because they love to ask you those nonsense questions. It's just the way it is. So make sure you guys do that before the test. And coarctation of the aorta. Which disease association they may give you on the boards? Turner syndrome, yeah. And then how do you detect that in physical exam? On an echo is easy, but on physical exam? For Turner's, but coarctation, how do you diagnose it? Where? Compared to what?
Your left and right.
No. because the coarctation is upper and lower extremities. Yeah. Yeah. So that's more like for a stenosis to subclavian artery or something like that. But yeah. All right. So I told you guys he drinks about 3 to 4 alcoholic beverages per week, and he doesn't add any sodium, but he snores, and he denies any hypersomnolence or headaches. The most common review system on patients with sleep apnea is snoring. You ask the partner, and hypersomnolence and headaches. It's quite common that they have daily headaches, and blood pressure is 160 over 90, pretty consistent with the readings. He's obese with a BMI of 35 and has 1+ pitted edema. Why does sleep apnea patients develop edema? Might, but there is actually a different reason. You guys know that the lungs and the kidneys, they work together to keep a pH balance in our bodies, right? The lung is pretty fast, the kidneys are a little bit slower, like in other words, it's minutes versus hours to days, right? So when you have chronic hypercapnia, like you retain carbon dioxide, the kidneys sense that, and the kidneys basically, they have a mission. The mission is like, you know what, we can't let this guy's blood become acidic, so why don't we help retaining some bicarbonate? And when you reclaim bicarbonate in the proximal tubule, it goes along with fluid, with water. So very commonly, severe sleep apnea patients, they have lower extremity edema. You're going to see these a lot in clinical practice. Okay? So basically, is sleep apnea common in obesity?
Yes.
Okay. So look at the study. Just more than 29 servings per week that are associated with secondary hypertension. So if you have 1-2 drinks, forget about it. That's not the cause. Okay? All right. So clinical prediction of sleep apnea, if you're obese, your chances of having it is like 50 to 90%. So if you were to use physical impression just by like a pretest probability, you're going to be right 50% of the times. These are basically prevalence studies showing that 85% in one series and 83% in another series in obese individuals. And this is the continuation of the question. Why don't you keep reading this question?
You refer him for polysomnography demonstrating an hypoapnea index AHI of 20 events per hour, which is moderate OSA. He begins CPAP and is now seeing me a month later. He uses CPAP nightly, sleeps well, and says that he feels more energetic. He still takes lisinopril, chlorthalidone, amlodipine, and metoprolol. His exam is unchanged, and his BP is now 157 over 88 instead of 160 over 90. Which of the following is most likely to result in control of his hypertension? A. Spironolactone 25 milligrams per day titrating to 100 milligrams per day is needed. B. An exercise program of walking 20 minutes 3 times per week. C. Referral back to the sleep clinic to adjust his CPAP mask or prescription since the therapy is not working. D. Referral to ENT for laser-assisted uvuloplasty. And E. Long-acting diltiazem 120 milligrams per deciliter per day, titrating to 300 milligrams per day as needed.
So in other words, the guy has a sleep apnea. He went in, he's complying with the mask, and there was really almost no change in his blood pressure. So they're asking you, what do you want to do? You want to add a medication? You want an exercise program of walking 20 minutes 3 times a week? Do you think that's sufficient? some low potassium diet recommendations, you need to spend some time and document it in your chart, because high potassium can be lethal. You know that, right? That's actually how they kill prisoners in this country. They give them a lot of stuff, including potassium. Okay, very good. So these are the effect of CPAP on blood pressure. Take-home message is, you treat the sleep apnea, the result on blood pressure is negligible, but it doesn't mean you're not going to treat it. Because the sleep apnea, we talked about this last time, associated with significant morbidity and mortality. We don't need to go over again, okay? These are I have two trials that actually showing the beneficial effect of spironolactone. So the ASCOT trial, they actually did, they had it's actually a pretty good sample, and then they had like 1,500 patients, and they randomized them in two groups. One group received the spironolactone, and the other group, they added another agent, whatever the agent was, hydralazine, diltiazem, whatever it was, right? So the results were actually pretty consistent in both groups. There's a reduction of about 22 delta systolic blood pressure drop on the spironolactone group, and also like about 9 millimeters of mercury drop in the diastolic group. This is another trial that was a smaller sample, but it was actually very well designed, and it showed that for 8 weeks they did what I like about the study is that they did a 24-hour ambulatory blood pressure, and the results were very consistent with the ASCOT trial. The Spiron trial showed that there's about 10-point reduction in those patients receiving spironolactone versus, some other medication. So, a take-home message: if you're confronted with real resistant hypertension, after you eliminate pseudo-resistance, the next drug of choice is to do spironolactone, unless you have advanced kidney disease or your potassium is high. You cannot use that medicine. Okay. For the textbook answer, if your GFR is less than 60, you're not supposed to use it. That's basically what the textbook, what the label recommends. If you are comfortable, like I use it all the time if the GFR is less than 60, because I need to use it. Otherwise, I have really no choice for my patients. But make sure you document that the patient was formally educated about low potassium. Okay, so how to control hypertension in most patients. So step 1, if you have heart or kidney disease, you give an ACE inhibitor or an ARB. You guys know that heart patients, they beneficial effects on remodeling, and mortality, survival benefit. If you don't have heart disease or kidney disease, the national, the Joint 8 Commission recommendation is to start the patients. They put amlodipine as a first line along with thiazide diuretics. So that's actually, if you think about the Joint 8 Commission, this is what I'm showing you because you guys are doing a cardiology rotation, cardiac and kidney rotation. So if you have kidney or heart disease, these are the first line agents, okay? If you have a patient with completely normal kidney function or completely normal heart, you always want to start with a thiazide diuretic. I personally like chlorthalidone because it's longer acting. It's a very powerful thiazide and it works very good. But the problem with the chlorthalidone and the thiazides is that you have to have labs before and after. Whereas amlodipine, if you're working in an urgent care setting, is a perfect medication. You just give it to the patient. You don't have to worry about any potential serious side effects when you prescribe it. If you're in the urgent care, if you prescribe a thiazide without labs, that's malpractice. So always remember that. And which serious metabolic abnormalities can happen when you prescribe a thiazide? Which one? Which electrolyte can actually kill people when you prescribe a thiazide? No.
Calcium.
No. Have you guys heard about osmotic demyelination syndrome?
Sodium.
Hyponatremia. So thiazide-induced hyponatremia is a serious clinical syndrome. So that's why you have to check labs about a week after you start a thiazide. You always have to check sodium just to make sure your patients are not becoming hyponatremic. If they already hyponatremic to begin with, and that's why I'm saying you need to check labs before and after. If your patient is already hyponatremic and you don't know the reason, please do not prescribe a thiazide because it's only going to make it worse. So that's an important